Welcome to the recorded version of the Grantmakers and Aging web seminar, Aging and Mental Health, featuring Robyn Golden, Director of Health and Aging at Rush University Medical Center, Kate Krajci, Coordinator of Mental Health Services of Health and Aging at Rush University Medical Center, and Mary O'Donnell from the Board of Directors of Grantmakers and Aging, from November 10, 2014. This event was made possible by a partnership between Grantmakers and Aging and the John A. Hartford Foundation. Technical and production support is provided by the American Society on Aging.
Hello, and thank you, Steve. Welcome, everyone, to Conversations with GIA. This is part of our continuing series of monthly webinars on critical topics in aging. Today's session focuses on aging and mental health. My name is Mary O'Donnell, a board member of Grantmakers and Aging and Senior Program Officer at the Retirement Research Foundation. I'm filling in today for John Feather, the CEO of Grantmakers and Aging. I'm delighted that so many of you have joined us today. Before we begin, we want to stop for a moment and thank those whose support is making today's webinar available free of charge to our audience. The John A. Hartford Foundation of New York, which provides continuing support for this series of webinars, and the Retirement Research Foundation of Chicago, which is co-sponsoring this particular webinar. We also want to thank the expert team at American Society on Aging for providing technical and production support for the series. Older adults face many stressors that can contribute to mental health concerns, yet these conditions often go undetected or untreated due to a variety of factors. Our guest today will discuss the unique aspects of mental health in older adulthood, including some common myths, proven treatment options, and future trends. In addition, we'll discuss some examples of strategies funders have used to address older adults' mental health. Joining me today are two experts in this field. We have Robyn Golden, Director of Health and Aging at Rush University Medical Center in Chicago, and Kate Krajci, Coordinator of Mental Health Services at Rush University Medical Center. Welcome to you both. So we're going to move to the next slide now. And Robyn, I'm going to start with you. We all have probably heard that mental health challenges can present themselves at any stage of life. But what is unique about mental health when it comes to older adults?
Thank you, Mary, and thank you all. Well, this has been a topic for very long in coming, and seems to we've embraced it in a whole different way more recently. So I'm pleased to see that happening. And part of why is older adults, just by age, their lives are complicated by so many different aspects: physiological, cognitive, social functioning, social isolation, and that's why so many issues are important when it comes to older adults and why mental health is unique. They're often not in the workforce. They often don't have the structure and meaningful activities of every day. So that's pretty critical. And mental health then, as a result, is critical to optimal functioning and physical health issues among older adults. So often, mental health and physical health are disconnected in different silos. And our third silo very often is aging and aging services. So those disconnects ultimately are not helpful for overcoming any sort of losses or indeed improving overall health outcomes. There are many losses associated with aging: changes in living situations, roles, their ability to perform certain activities, sensory impairments, and the interaction between age-related circumstances and mental health symptoms complicate our accurately identifying what's going on, diagnosing, and treating in older adults. There's very often confusion between dementia and depression, normative grief and depression, because there's sometimes very confusing presentations and comorbidities. Very often someone can appear depressed, have some confusion, and we find out a week later they have a urinary tract infection. That's part of the complications with older adults and mental health issues. And it's very much complicated by ageist stereotypes that override and complicate assessment and identification. So often when people do present with mental health systems, it's in the primary care setting. And unfortunately, too often, as a result, things are not picked up there, or there's a sense that there are very few treatment options, and the stigma that some providers have get in the way. And all those cohort issues with this current group of older adults who grew up at a time where mental health was something that you don't talk about are often holding back and not being upfront as a result.
I see. Okay. So given all that, can you help, Robyn, as we move on to the next slide here? I want to make sure we have a handle on the prevalence rates. So how common are mental health issues in older adulthood?
Great question. At least 1 in 5 people over the age of 65 has a significant mental health disorder, and that total number will double over the next 30 years. There are numbers all over the place, but around 20 to 25% of older adults meet the criteria for some form of psychological disorder. Now, those are older adults living in community-based settings as well as facilities, as well as nursing homes, looking across our many sites of care. The number of people over the age of 65 with psychiatric disorders will more than double by the year 2030, from 7 million in 2000 to 15 million. So these are very significant numbers, very important, and again, so often missed. We hear about suicide all the time in younger adults, teenagers. We often don't hear about it in older adults, yet it is really highest among older adults than any other age group. And we can speculate why we don't hear about it much for lots of reasons, ageism one of them. When people are chronically ill, maybe you write off the death as related to that physical illness as opposed to that mental health issue. Depression is a bit better understood than anxiety, but both need further investigation. And unfortunately, many believe all mental health issues are just a part of normal aging and, keep their eyes closed or their heads in the sand when they think about what's going on with someone and, don't believe in more of our pessimistic world, don't believe that people can be helped and changed. I think the areas that are growing, too, in number are substance abuse, particularly not just alcohol, but prescription medication abuse, as well as drugs off the street more and more we're going to see. And then the whole area of trauma, where early trauma either gets ignited for the first time or reignited with the onset of aging and the losses related to that.
Okay, so there's a lot going on there. So share just a little more context then. You alluded to some challenges around perceptions, but help us understand better why mental health is perceived as such a challenging area when it comes to issues facing older adults.
Sure. Well, part of it is just...
Steve, we can move to the next slide for that.
Oh, thank you. Part of it is just that current preventive services are very limited. We have added some questions into the Medicare annual wellness visit, which is promising, yet we're seeing a very little uptake in the Medicare annual wellness visit, so that's unfortunate. We don't see much of our Title 3D services, which are our health promotion services, going into mental health. So for all those reasons, it's a greater challenge. And older adults with mental disorders are more likely than younger adults to receive inappropriate or inadequate treatments. Again, that feeling that providers sometimes have or family caregivers might have, or the older person themselves, that why bother, what really can be done, this is normal, I'm hurting, I'm in pain, so of course I'm depressed. Or I'm fearful about my future, I have cognitive problems, and of course I'm anxious. And there's very little looking across comorbidities to say, even though you may have a dementing illness and you may be in the beginning of stages of that, there's still something we can do about your depression and your anxiety. Only 1/3 of older people who live in the community and who need mental health services actually receive them. So that's very scary as someone who's been working in this field for a long time. We've seen growth in some of the research on the causes and treatments of problems in older adult psychiatric problems, but we have And we've seen some evidence-based uptake of interventions. But again, the dilemma is older adults do not seek treatment in the same ways. There have been studies that have shown when an older adult program is funded that says older adult mental health program rather than just something coming out of a all-age mental health service or a family service agency that doesn't specify this program is serving older adults, there is greater accessibility on older adults' part. They will reach out more easily when they know they're going to be interviewed or assessed or welcomed by someone who understands older adult mental health issues. So that's really important for funders to hear today. And so that's an important piece. And that's why I think our next question.
I'd be interested to hear just a little bit more as we move to the next slide about the context.
And that's why we're really viewing this today as an impending public health crisis with the dramatic growth in just the numbers of older adults with boomers, et cetera. There are going to be a lot more mental health issues out there to contend to, and we are so not ready for that. Our services are far behind. It's very hard to find a mental health provider who knows older adults, who can go into a community setting, go into a home, all of which are critical in serving older adults. So there's more attention always given to physical health than mental health. I've always wanted to put on a campaign for older adults as well as providers saying, you fix your feet when they're hurting, why not your emotions? Because we should try to make it as normal as possible. In a way, sometimes the way we do engage older adults who are reluctant and fearful is by saying, if you were diabetic, wouldn't you get some help for that? Well, depression is not different than diabetes, and there are things that can be utilized to make you feel more helped and more hopeful for the future. Very important IOM report of the last couple years talks about the geriatric mental health care shortage.
And that's Institute of Medicine?
Yes, thank you, Institute of Medicine report. And and why there's that shortage has to do with sometimes, as the Hartford Foundation knows for sure, there has been a lot of energy pumped into trying to attract people to the field of aging, but sometimes it's not viewed as the most exciting part of our healthcare delivery system, and we've tried to undo that and gerontologize the workforce for sure. But in terms of care models, there's often less reimbursement or no reimbursement. It's amazing how few providers take Medicare at this point, how hard it is to find providers who take Medicare when older adults do have Medicare. So that's concerning, and that's why there's not only the shortage, but the public health crisis pieces. There aren't the services as well. So that expertise gap, as we call it, is due to that inadequate training, but also sometimes a failure to incorporate evidence-based care into routine care. So the summary there is that older adults are not getting the care that they need and could benefit from, as evidence has shown. In addition, this has unbelievable implications for healthcare utilization overall, because older adults with depression have nearly twice the number of inpatient days and outpatient visits. So when you hear in our healthcare language discussions about the triple aim, this complicates reaching that triple aim, which is improved quality, health, and reducing costs. So mental health should be at the table, as well as mental health providers, when thinking about those overall and overarching healthcare goals with our current transformation in healthcare.
Right. Okay. Fantastic. So, Robyn, thank you for that great introduction to the topic and the many layers that are present within it, and really great background. I do want to remind our audience that you can submit questions in writing in the box on your screen, and we'll discuss those questions during the second portion of our webinar. Let's turn now to Kate. So Kate, based on what Robyn has just shared with us, there clearly is a need to address mental health and aging, and realistically, some very profound challenges in doing so. So as we move on to this next slide, I'd be interested in hearing from you if there are effective approaches and treatments available despite these challenges.
Sure, absolutely, Mary. And we're actually going to move one slide forward as well. The gold standard for treatment of mental health, regardless of age, is a combination of medication and psychotherapy or talk therapy. And that being said, we know that psychotherapy is very much effective with older adults. As Robyn mentioned, there's often this perception that you can't teach an old dog new tricks, and that absolutely is not the case. So there are a number of psychotherapeutic approaches that an individual practitioner can use that show to be able to make changes in the mood of an older person. Those are things like cognitive behavioral therapy, interpersonal psychotherapy, problem-solving psychotherapy. But we know that grant makers often are not able to fund these kinds of gold standard medication psychotherapy combos. So what I think is also important for people to understand is that there are a number of programs that we'll talk about later that do show effectiveness in terms of screening for mental health concerns, as well as team-based care structures that focus on mental health issues. And as Robyn said, a lot of those team-based approaches are not reimbursable right now or are very complicated to have a reimbursement. And those are really great areas that grant makers can consider in terms of effective treatments.
Great. So just as a starting point, give us a quick rundown. Where is treatment usually offered and by whom?
Sure. We can go to the next slide, which gives a little overview for the viewers. I think it's helpful to think about the settings in which older adults often access mental health services and then the providers. So we know that primary care is the area that everyone, regardless of age, goes to as their first source for mental health treatment. This is particularly true within older adults. So we can often think of the healthcare system as the entry point, if not the actual place of service delivery. Many older adults, unfortunately, never move beyond the prescription that their primary care physician prescribes to them, even though they might benefit from some of these other non-pharmacological interventions in terms of improving their mood. Certainly, we also know that within the healthcare system, there are providers of psychotherapy services or some of these team-based approaches that we'll talk about. Then I think the next area where older adults are very frequently getting their mental health services is actually within the network of aging service providers, whether those are providers through the area agencies on aging, nonprofit organizations that are not affiliated with those areas. Aging service providers are an area where especially one-on-one interventions happen. Of course, we've got that mental health system, which is separate even yet from the healthcare system and the aging system, so yet another system that an older person might interface with. And those are our traditional mental health clinics out in the community. And then certainly there are practitioners in private practices, although as Robyn mentioned, those are decreasing in their numbers in terms of those who accept Medicare and are easily accessible. So like we mentioned, primary care providers might be a provision, a place where mental health services are provided. Psychiatrists are going to primarily be focused on specialty medication management. Very few psychiatrists these days are also doing talk therapy or psychotherapy. Psychologists and clinical social workers are really the primary professionals doing psychotherapy or talk therapy. But we also know that nurses, case managers, and even people who do not have formalized bachelor's degrees or master's degrees are also involved in the healthcare provision to older adults as well.
Okay, so it is pretty wide. Then given that, I want to dig deeper. You mentioned some of, the fact that just medication or one-on-one talk therapy is not the whole array of the arsenal that we have at our disposal. So I'm curious to hear more about options that grant makers could consider exploring at a local level. I know, many funders are particularly interested in learning about proven program models that work well and can be replicated relatively easily and hopefully relatively inexpensively in local communities. So do any evidence-based program models exist for mental health and aging? Talk to us about that.
Yeah, absolutely. So if we advance to the next slide, there are several that connect to that concept of screening. So as Robyn mentioned, so often older adults don't have access to mental health services or don't get the treatment that they need. And part of this is because these concerns go unidentified. So two of these areas are listed here on the slides, and these evidence-based programs focus on screening efforts. Healthy Ideas is very widely understood in the mental health and aging area, and this is focused on depression. This is also integrated into a community-based agency, and so it's meant to be an intervention that can be provided as part of regular case management activities that a community-based case manager might be offering to an older adult for another reason. So this really is looking at depression screening, providing education, some simple behavioral change activities which have a psychotherapeutic component to them, and then, of course, care coordination across all these numbers of systems. So the great thing about Healthy Ideas is that it does get at this idea of identifying people, but also gives them a first entry point into treatment, might motivate them to pursue a more formalized psychotherapeutic intervention, and can be offered by community case managers as opposed to, say, for example, a traditional mental health service provider like a psychologist or a licensed clinical social worker, although many case managers in the community are licensed clinical social workers. The next focuses on substance use, which Robyn mentioned is really a growing area in older adulthood. So screening, brief intervention, and referral to treatment, otherwise known as SBIRT, is widely known to be effective in identifying substance use patterns and, again, preparing someone to consider exploring more formalized treatment. What's great about SBIRT is that it really can be offered in any sort of setting by any level of professional because it's not treatment. It is this idea of identifying people who have a concern with any substance. In older adults, there's an evidence-based SBIRT program that looks at alcohol and what we call psychoactive medications, so medications for things like anxiety, sleep, pain that tend to be addictive. And then we offer education through this so that the older adult understands what are some of the risks of the substances that they're using. This hopefully will prevent kind of problematic use from turning into a true substance abuse disorder. And if a substance abuse disorder is found to be present, then the intervention focuses on motivating that older adult to consider formalized treatment. So this is really a great way of providing education as well as intervention, and again, can be offered by a professional at any level of training. So there's actually a few more that we'll talk about that are actually treatment programs. So we'll look at the next slide, please. And so these are, great, thanks. So these are two interventions that are, again, focused on depression. The first is called IMPACT, which many of you may have heard about and has received extensive support from the John A. Hartford Foundation. So IMPACT is based in primary care, that setting that we know many older adults go to for services and mental health support. And this is one of these team-based programs. And it includes not only screening, but also psychotherapy and a lot of symptom monitoring via a depression care manager that's based in the primary care clinic office. This is a more long-term treatment, but I think is a really great thing to consider, especially since it bridges that gap between mental health and physical health, like Robyn was talking about. And then another is called PEARLS, which many of you may also be familiar with. PEARLS is, again, integrated into community-based case management, so an aging organization or other nonprofit organization that offers care management to older adults could consider this. It is in-home, so it takes down that barrier of transportation and getting out for services. And it, again, is a team-based approach that includes psychotherapy and typically targets not only depression that meets what we call diagnostic criteria, but also targets depression that is just below that diagnostic criteria. So this has a great opportunity to potentially prevent a full, what we call depressive episode.
That's really encouraging. It's great to know that there are existing program models out there that have been developed, tested with older adults, and are ready to roll out in the community. So thank you so much for walking us through those models. Now, thinking beyond these evidence-based programs, are there other ways grantmakers can help older adults get the treatment they need? I remember Robyn mentioning, for example, a lot of big barriers earlier in our conversation. So what else is in our toolkit?
Sure, absolutely. Let's take a look at the next slide. I think there are so many different ways that grant makers can fund not only actual services in terms of potentially subsidizing some of the cost of services or perhaps just offering direct services themselves. I think a huge piece is that consumer awareness and education. Like Robyn was talking about, there is this stigma out there that somehow depression and anxiety or other mental health concerns are a normal part of aging, which they're not. And that is something that consumers and older adults, as well as family caregivers, need to be able to understand is not the truth. So we need consumers to be able to know what are some of the symptoms they should be aware of. What can they do to get help if they feel like this is something that they need some intervention and support around. So I think just awareness and education campaigns are a huge potential area. And similarly, there's the provider education. So Robyn certainly talked to the workforce issues, and Hartford has done a lot around increasing that workforce, but we can never have enough mental health providers or programs out there. So this might be provider education not only in those typical areas like social work, psychology, psychiatry, primary care, but also in the aging network. We know that some providers in the aging network don't have a mental health background, so they're not familiar with these issues. So really being able to train the people who are seeing older adults in their homes on a regular basis on what are the signs to look for and how they can get them connected to help is really great. I think another area that is often underlooked in terms of education are housing providers, assisted living, nursing homes, perhaps nursing homes to a lesser extent, but certainly in independent senior housing, affordable senior housing, various retirement communities, assisted living communities. Many times the staff there do not have any training in mental health services. And those are huge areas where there's a population of older adults who have gone through a lot of changes in order to get there, or might have other psychosocial stresses that may influence mental health. So I think thinking about those providers as another area that could provide or need education and training is another important thing to not overlook. Certainly we talked already about subsidizing services so that older adults can better afford treatment. And then, of course, we've got the evidence-based programs, some of which we talked about today. There will be an issue brief posted on the GIA website regarding mental health and aging. And at the end of that, we have some resources where everyone can search for other evidence-based programs or learn more about the ones that we talked about today. There is one database through the National Council on Aging and another one through the Substance Abuse and Mental Health Services Administration. But in addition to funding these evidence-based programs, we might even need to adapt some of them. So we certainly don't know how effective all of them are for different minority populations, so that would be a great thing to consider. And certainly we might think about supporting people in developing new models that are rooted in these evidence-based treatments. These evidence-based treatments are great and ready to go and ready to be replicated. At the same time, we know that there might be other models of care that would also be effective for a particular population, in a particular setting, in a particular region. So that certainly is something that grant makers should consider. There also are opportunities to support coalitions focusing on mental health and aging, or even substance use and aging. We know that there is a national coalition on mental health and aging and many state coalitions. These are often unfunded or underfunded, and the professionals who participate in them essentially are volunteering their services to be able to participate. And some of this results in policies at a local level not moving forward as quickly as they might be able to if there were dedicated staff or other financial support for these organizations and coalitions to be able to truly engage in advocacy efforts that are needed. So supporting local coalitions regarding these themes might be helpful. And certainly if foundations are interested in supporting advocacy, we can always use more advocacy not only at local levels but also at a federal level around provider issues pertaining to billing, reimbursement structures. We know that some mental health professionals, for example, marriage and family counselors right now cannot bill Medicare. That's a whole other provider pool that would be able to offer services to older adults if that policy changed. And certainly incentives for training would be helpful as well as we consider how we can increase the workforce.
Thank you, Kate. Really useful insights. It sounds like there's not a lack of directions to go, and it's encouraging to me to hear that the field of aging has come a long way in this realm, given that some of these possibilities might not have been as realistic in the past, but clearly there still is a lot of important work to be done. I want to switch our focus now and talk about grantmaker involvement and funders' responses to these challenging issues. Before we go there, I do want to address a couple of the questions that have already been posed, and thank you to those of you. We've been getting some great questions, so I'm really looking forward to our question and answer portion of the call, and encourage those of you on the line to continue to send in comments or questions. Just a couple housekeeping questions that have been posed. We've been asked whether the slides will be available for future reference. The answer is yes. This whole webinar actually is being recorded and will be archived on the Grantmakers and Aging website within about 2 weeks. So you can visit www.giaging.org and see a copy of the slides along with the audio of our discussion today. And there also has been a question about whether there will be access to any of the citations and other research-based aspects of the conversation that we've been having so far. And the answer to that is yes as well. As Kate mentioned just a moment ago, this week a issue brief on mental health and aging has been published on Grantmakers and Aging's website. So again, www.giaging.org. If you go to the Issues tab on that website and look for mental health, you'll see a much more detailed and extensive discussion of many of the things that we're talking about today, as well as research statistics on many of the points that have been raised. So that will be a useful tool for you. All right. Now, putting on my grantmaker hat, I thought that I would share some examples of how funders are responding to these critical needs. So I wanted to begin, as we move to the next slide, by thinking about 3 different tools that we often have, which are ways that grant makers can inform, convene, and invest in the area of mental health and aging. So on the next slide there, you'll see that one of the first strategies that we all can use is to inform our grantees or fellow funders, other constituents and partners within our communities about the unique aspects of mental health in older adulthood. So I hope that, as I said, today we we intentionally took sort of an Aging 101 approach to today's webinar, but this topic is so rich with such complexities and also such exciting opportunities that I really do encourage you, if you're interested in sort of taking more of a 201 level to this topic, to check out this newly released mental health issue brief, which we are so fortunate to have courtesy of Kate and Robyn at Rush. And it provides additional details, as I said. It also, I think you would learn and continue to inform your own knowledge base by checking it out. But it also, I think, would be a great tool to share with your coworkers, perhaps some of you who work in grant-making organizations that don't exclusively focus on older adults. You might want to just route it around to some of your other staffers who might not work as closely in aging issues as they do, just to help inform them of some of the trends and sort of, become a mythbuster with us around those things. It also could be a great tool to share with board members. Again, every foundation is different in terms of how they do their board education efforts, but at the Retirement Research Foundation, for example, we regularly bring in grantees and other experts from our communities, and using this tool as a primer or background piece for perhaps a discussion or a presentation that you might have from a local expert in mental health and aging would be, I think, a way to sort of prime your board so that they know a little more about what the real-world framework is around these issues. And then when a proposal or an opportunity for a new initiative comes up, they'd have that frame of reference. The second strategy that I want to talk about is that of convener. And we know that actually that's, in my opinion, I think one of the most valuable roles that funders can play. Our position in the nonprofit sector allows us to bring different groups together for discussions that they might not be able to have in other settings. So I encourage you to consider convening groups of grantees to learn about this topic, share their successes and challenges with one another. There's a huge opportunity here for funders to convene service providers from the quote-unquote aging realm with those who traditionally work in the mental health realm, to break down some of those silos that Kate and Robyn were discussing with us. Consider hosting a Lunch and Learn series where each of the evidence-based program models Kate discussed is delved into a bit deeper, or maybe the group can identify particular needs and opportunities, unique in your own community and the dynamics at play there. So that, of course, is a very small investment. That's some sandwiches or maybe bagels if it's more of a morning crew. And of course, don't want to forget the value in convening other funders, having those come together who perhaps have a strong interest in health and sparking a discussion about the discussion of mental health in older adults and the proven strategies that can be implemented. So we hope that you will continue to inform and convene others around this topic. As we move to the next slide, though, we know that, of course, when it gets down to it, grantmakers' most potent tool is money. So I wanted to run through a few ideas around strategies that have been used to invest in mental health and aging, just as food for thought. So I list here a few of the resources that are out there where you can learn, as Kate mentioned, more about the existing evidence-based models. National Council on Aging has one. SAMHSA has one. Of course, the other GIA members and grant-making partners that you have at your disposal are great resources. Just to make it a little bit more concrete for you, I think it's important to note that many of these models can be replicated in your local community for relatively modest amounts of money because we benefit from the investments that our other grant-making peers have already made in the development and the dissemination of them. So Retirement Research Foundation, for example, has awarded several grants in the realm of, $15,000, $20,000, $25,000, $30,000 for replication of pearls and healthy ideas. And our trustees really like the fact that they can make a grant for one of these programs and be relatively confident that the program is going to show positive results for the participants. And I know that for us, where we never have as much grant-making resources as we would like to go around, that's something that appeals to them, to know that this is an investment that's going to have results. But, as Robyn said earlier, there is need for adapting evidence-based models in deliberate ways. I think that can't be understated either. And Kate highlighted it as well. As we look forward to meaningful ways that funders can make a difference, I think that's something we should keep an eye on. Of course, this needs to be done very thougthoughtfully with sensitivity to what elements of the program made it successful in the first place. But, for example, again, to just throw it out there, Retirement Research Foundation has a strong interest in cultural competency. So we've helped a local social service agency, this was the Chinese American Service League here in Chicago, work with the program designers of Healthy Ideas to have its training and client materials translated into Mandarin, the primary written dialect of Chinese. So that's just another example. And then I know that our friends at the Archstone Foundation, if we want to take more of a regional approach, had launched an initiative on expanding mental health services in the state of California, where 9 organizations were awarded grants to expand existing mental health service programs that were identifying and treating depression in community-dwelling older adults. I believe that initiative is wrapping up shortly, so look forward to hearing more from Archstone when they pull together their lessons learned. And as a final example, as Kate mentioned, our friends at the John A. Hartford Foundation, together with several funding partners, probably many of you on the phone, have supported Project Impact. Most recently, the focus of those efforts have focused on the adoption of the model using 2 different strategies. One, increasing the demand for impact, and 2, increasing the supply of health professionals trained to provide the care. So they're looking at it from both ends, which I think is really smart. So they're funding some marketing and communication efforts to try to enhance the demand, get the word out there, and then they're also funding some training and technical assistance projects, which are going to support the increased supply. On this slide, you'll also see a couple other strategies for investments. I do want to be able to hop into our discussion mode because there's just a ton of great questions. But don't forget that there's value in investing in training and continuing education for professionals serving older adults. You can look to investments in professional associations or local universities, community colleges, others that are developing certificates in geriatric mental health, all really great investments. And then the public education and advocacy efforts that we've already talked about can't be underscored. I do have there the website for the National Council on Mental Health and Aging that Kate mentioned earlier. So look up and see if your state is doing anything that you can tap into. All right, I'm going to stop and we are going to switch into questions. So we have a lot of good ones. And I want to start by asking Robyn. Robyn, this is really cutting right to it, but we have someone who's asked, what hope is there for improved public policy making community health services more available? Is there hope?
Great question. I think we should be hopeful that there will be more integrated mental health and physical health systems of care out there, both mental health connecting to federally qualified health centers, and SAMHSA has some initiatives. Substance Abuse Mental Health Service Administration has some initiatives where they're trying to integrate more behavioral health into physical health into behavioral health. HRSA, Health Resource Service Administration, does as well. So I think in that regard there will be. I hearken back to the Positive Aging Act that was, it's about 11 years old now, 12 years old, and really had components where there would be mental health specialists within AOA, ACL, Administration on Aging, Administration for Community Living, and that there would be aging experts in SAMHSA, and that there would be a whole initiative around primary care to develop screening around primary care and intervention. A lot of the work that Retirement Research has supported with our Brighton project here at Rush, which is around, kind of involving a multi-interdisciplinary team around primary care to address depression and anxiety in older adults. So I think there's hope around that. These are tough times, and, you know, is mental health at the table? They're a little more at the table, but there's a danger as things get shaken up potentially that they could be removed from the table too. So I think it's incumbent upon us, as Kate said, to advocate as much as possible, tell our stories, talk about the people who aren't being served. There are so many. What we need is, you know, housing for people with mental health issues who are older adults, in-home care management that's much more assertive in nature. Those things get missed all the time. Milieu programs, all of that, because being with a group really, you know, can stave off what loneliness and isolation can do to a person as they age. So I do think there's hope, but I also think there's just as much as we can push the evidence and explain how it has an impact on greater healthcare outcomes and costs, we'll be in the best position we can be in terms of integrating with ACOs and patient-centered medical homes and things such as that, and even bundled payments. These are all things being talked about in terms of healthcare reform, and mental health has to be a piece of all of those discussions.
Great. There's also a question here, switching, Kate, probably back to you on more of a clinical side, a question about the role that pastors and faith leaders play in some of these approaches to mental health and aging. So can you talk us through that? What is that? Are those other folks that we should be aware of in their role to address this?
Sure. So I think it's a fantastic point that one of our participants brought forward. I personally am not aware of any particular evidence-based programs that utilize pastors. I welcome Robyn or Mary, even yourself, if you are aware of any that specifically use that particular area. Certainly within a medical setting on an inpatient level, often pastors and chaplains are the ones that are providing some of the emotional support to patients. At least here in the Chicago area, that typically does not extend on an outpatient level or on a community-based level. But we know that so many people seek emotional support from pastors, clergy in their faith community. So I think anything that we can do to support faith communities, again, in understanding what are the kinds of signs and symptoms to watch for. Many chaplains are already trained in that. So I think that is a huge untapped resource and a great area for grant makers to think about.
Okay. And we have a couple different questions that relate to cost and price and billing. So first of all, do either of you happen to know if there is a cost to Healthy Ideas or impact? For example, if Healthy Ideas were brought to a primary care group's case managers, is there a cost to training them on the program? And all those sorts of things. Talk to us about billing and costs.
It's Robyn. I'm sure there are costs associated with both. I know when there were the replication grants for impact out there, there was like $5,000 seed money for people to start those programs. I'm not sure that actually covers the cost. But again, this is where we get into the difficulty, even though there's mental health parity, a lot of what Healthy Ideas is about and a lot of what impact is about, it's not traditional psychotherapy where you can bill a payer in terms of Medicare or even commercial insurance and or Medicaid, but they have their services that unfortunately have been not been viewed as billable type services. So that's something that many of us have fought long and hard about for many, many years to try to get away from the traditional image of what mental health intervention is and think more broadly. So I don't know the cost, but I know the issues, and they're definitely big issues.
Right. Okay. We do have a comment here that I want to make everybody aware of. Our friends at the Archstone Foundation have just announced the release of Care Partners. It's a document called Care Partners, Bridging Families, Clinics, and Communities to Advance Late Life Depression Care. That's something that if anyone is interested in knowing more, they can visit www.archstone.org for details. So that's something I wasn't aware of and look forward to checking it out. Thank you, Laura. All right. Also, there's some interest here in understanding sort of, well, this is, I guess, more of a comment too, but just the maze of getting the right services for older people and sort of connecting them in ways that make sense. And that person isn't posing a question, but I think we all feel your pain, and I think hopefully some of these more systematic approaches that we've discussed could get there. We also have this. Oh, there is a comment. Go ahead, Kate.
Sure. So I think that part of what we also need to think about in that area is how can we also engage the family in helping us to identify. So oftentimes we might be learning about an older adult's symptoms through their caregivers. So we need to make sure that we're doing that as well. In terms of like the big system, it is really confusing. But oftentimes if you can at least identify perhaps your local area agency on aging, many times those organizations have a referral database. They themselves might have organizations under their umbrella that are offering mental health services. So through that, there might be a beginning stage to get a point of entry into kind of these traditional either psychotherapy referrals or perhaps into one of the evidence-based programs that are being implemented by a community-based agency. But again, if we can also include family members in part of that identification process, that can be a huge help too.
Yeah, really smart. We can't forget the focus on the family members. So we have another question here where someone is observing that many of the mental health services and programs that we've been discussing today focus on depression. And the question is, are there any programs for the myriad of other mental disorders that older adults might experience, such as anxiety disorders, personality disorders, bipolar? Robyn, Kate? Kate has
Sure. Sure. This is Kate. So I think that the reason that so much is focused on depression is that depression is the most common mental health condition within older adults, and so it's the most researched and most well understood. And it also significantly increases a risk for an older person attempting suicide and potentially completing suicide. So I think that's why there is such a focus on depression. But I think the participant is absolutely right in identifying the fact that there are many other mental health conditions that need intervention. And I'm not aware of too many that focus on other diagnoses aside from things like expert for substance use. Some of the evidence-based programs will tack on anxiety, but I think that this is another huge area. So when we talk about looking at an evidence-based program that exists and considering making an adaptation, certainly an adaptation for a particular other diagnosis might be helpful. This also is where we might need to be able to fund new programs to create a new evidence base around a diagnosis that perhaps we didn't really understand as much in terms of the intervention options. And it looks like Robyn has a comment as well.
Well, having had a lot of experience supervising people who are doing mental health work with older adults, probably the most time-consuming situations in those discussions have to do with people with personality disorders too, and there's no absolute program with people who are struggling with those issues. Very few hoarding programs, and we have to remember that when we talk about mental health and aging, we're talking about the majority of mental health issues are later onset, but then there's a whole bunch of people who are growing older with severe and persistent mental illness and may need very different things than what the later onset folks need to.
Mm-hmm. Okay. Very good point. So I do have a clarification here on one of my earlier comments. Want everybody to know that the Archstone site that I mentioned, it has what they actually were announcing was a new RFP, a new request for proposals, and I sort of presented it more as a report. Huge distinction. Apologies to our friends at Archstone, and thank you for the clarification, Laura. So it's an RFP for a new funding opportunity in California. So check that out if that would be relevant to you. All right. Another good question here about what services specific to this special and unique mental health needs and barriers of the LGBT community. Can one of our experts address that?
Sure. This is Kate. So within the LGBT community, we know that they face higher mental health concerns than their heterosexual counterparts, and this is particularly true for people who identify as transgender. So we know that this is a population, a subset within aging that really needs additional attention. Because we are only recently starting to understand the needs of the LGBT older adult community, I don't think that there are any evidence-based programs specific to LGBT older adults relating to mental health needs. But I would love to see how some of the ones that we talked about today would work within perhaps an LGBT organization, an aging organization. I know that there are many out there that now are starting to cater to the needs of LGBT older adults. So that's a fantastic thing for funders to consider.
Great. And we talked a little bit about the role of the family, but there are a couple other questions that people are presenting about caregivers. Can one of you discuss caregiver depression and caregiver mental health needs and the role that plays? What do we know about it? What are we learning? What should we be looking for?
So we know that many caregivers of older adults do have mental health concerns, and those caregivers who care for a person with Alzheimer's disease or dementia, about 30% of those caregivers actually meet diagnostic criteria for major depressive disorder. So identifying caregivers not only as a person who might be able to inform us about the needs of an older person in their life, but also identifying caregivers, period, because they themselves have their own unique risks for depression is essential. So I would really encourage that as well. Am I forgetting the other part of that question?
You're not.
Okay.
That's great. And to my knowledge, there aren't necessarily, evidence-based programs. There certainly are evidence-based programs designed for caregivers that funders and others on the phone could know about. And I think that many of those do touch on depression and mental health.
Well, I certainly hope the new Institute of Medicine report on caregiving will address mental health issues related to caregivers, and just the fact, Mary, that people don't really even assess what's going on with a caregiver, either physically for themselves or emotionally, is a critical factor that I would want to advance in any sort of thinking that we do around mental health, because that would be very important. How are they doing? Can we find interventions for them as well?
Yeah. Robyn, this may be a question for you if you want to keep the phone. So there's a question just kind of getting us up to speed on the Affordable Care Act. And did it expand access to mental health services for older adults? Just clarify that aspect for us.
Well, it happened simultaneously and reinforced some of the parity discussion in terms of reimbursement. It did indeed. And I think what it did stress as well is aspects of care coordination and integration of behavioral health and physical health aspects of care. So in that regard, it did reinforce mental health. Could it have gone a little further? Of course it could have, and particularly if it had gone into more long-term services and support, which is part of healthcare. Most of us think of it as. It would have been nice to have included a mental health component to that as well, because again, our silos seem to be widening at times in terms of aging services, mental health, physical health, long-term care. And so how do we cross that? And that would be a way to do it. And so I think we still have a little more push in that area. And hopefully will be future adaptations of transforming care, which will be needed for not just older adults, but people of all ages.
Wonderful, wonderful. And with that, we are going to close our conversation today. I genuinely want to thank Robyn Golden and Kate Krajci from Rush University Medical Center for their participation in today's program. We thank you for all you do to make life better for older adults. You two are really experts that we're so lucky to have working on behalf of our nation's older adults. We also want to thank the John A. Hartford Foundation and the Retirement Research Foundation for its support of this program, as well as the American Society on Aging for their technical expertise. And finally, I want to thank all of you for participating in today's webinar. Thank you and have a great day.